really good question. If you can't see the question, if you're not following, Lisa asked, regarding duplicate variables, what do you do then if you need the disaggregations? Would we recommend putting in validation rules to control the totals that are the same? Yes, I actually would recommend putting in validation rules. So if you do need the disaggregations, you have to have the data in multiple places for whatever reason. I think a bare minimum would be to put in validation rules that check to make sure that there is some kind of agreement across the between these two different programs. The point that Surajit was trying to make, or made I think quite clearly, was that if you are using these, a lot of times the same values that are being asked across multiple programs are oftentimes used as denominators in some of our key indicators, like our coverage indicators and that kind of thing. Like, for example, expected pregnancies and total number of deliveries, that kind of stuff. That value is useful in many different programs. And if we're asking it in multiple places, there is increased opportunity to have mistakes with that data being entered in any single one of those places. And that also means that our indicators across programs may not be comparable. That if we are asking for the number of deliveries in 4 different places because of different programmatic requirements, and they get it wrong in one place because they're just tired, they're worn out, they're they're nurses, there's babies screaming in the background, there's a line of expectant mothers around the corner waiting for their A&C visit checkup. There's just a lot of reasons why people will be distracted at the facilities, and so if they put that number in wrong in one of the 4 places, then that potentially throws off the indicators, and then all of a sudden those indicators are not comparable across multiple programs, which could be very problematic for you as well. Nora, did you have a comment to that one as well?
No. I think best practice is not to have duplicate data variables because it just creates, it burdens the facility staff, and they are so burdened with data collections. We need to be very caring about our facility staff, and one of the ways of helping ensure good data quality is to collect as little as possible. And so the less you collect, the more easy it is to do data quality checks, the more easy it is to discuss the data quality issues with facility staff and help improve the data.
Hamilton asks, and I totally agree with that. I think that's extremely important, is your goal as HMIS managers or programmatic people should not be to capture more data or increase the reporting burden. Your challenge should be to minimize the reporting burden and capture as little data as possible. And I'm saying that because there's a lot of experience, a lot of research out there that shows the more data you capture, the more likely you are to have data quality mistakes, the more confusing it becomes, the less usable your data becomes. You need to minimize the points of data capture. You need to minimize the values, the data that you do capture, to just those key values that are actually used in indicators for decision making. There was a really interesting assessment quite a few years ago that found that in quite a few countries, well, I won't name the countries, but it was about 7 countries that captured it was about 80% or 85% of the values that they captured were always zeros, right, at the facility, always zeros. Well, what is the point of actually getting that data if it's always going to be a 0, right? And it just makes more burden for the clinic staff, and ultimately decreases data quality, which then has side-on effects, spillover effects to data use.
Scott, yes, I want to emphasize that we find in many countries that such a large percentage of the data is zeros. And I don't think that the problem of what it does to have all these zeros is completely understood. It overloads the server, it overloads the facility staff, it just creates problems, and it gives you no value. There's no value in return. I think we must also be very clear that disease surveillance in terms of weekly disease reporting needs a zero. We're not talking about that. We're talking of routine aggregated data that has 75, 80, 85% of the time zeros. That's where the problem lies.
There was an additional question. Hamilton was asking about capturing data at a mobile clinic versus a health facility. I think that there's a few ways to approach this. It's very contextual. So if the mobile clinic is an outreach or an extension of the health facility, and if it is, then it may be appropriate still to capture that data against that health facility. Or if the mobile clinic is not associated with any health facility, if it's just its one-off event, and in which case I actually probably wouldn't even make the recommendation that it's captured in aggregate. I would make the recommendation that you capture that data in event capture in DHIS2. But maybe Hamilton, in the comments here, you can provide a little bit more detail or explanation about what these mobile clinics are that you're talking about, so we can give you maybe a slightly more specific answer. Lisa was saying that she was not so much referring to duplicates within different programs, but rather collecting the same form data with multiple disaggregations. Right, so like having multiple different disaggregations for the same data element. So maybe in one area you're capturing malaria cases by male and female, and in another area you're capturing malaria cases by age buckets, like under 1 to 5, 5 and above, or something like that. In which case, again, you can use validation rules to make sure the summations of those are equal. I don't know if that was your answer to your question, Lisa. Fernando brings a good point here. He says that the duplication is certainly a point of discussion, and yeah, we could really spend probably the rest of this course talking about it, to be honest with you. I totally agree with that. But he says that there are different programs capturing the same data, and it can be used in as a way of validation, right? So if the RMNCH program is capturing the same data as the PMTCT program, then you can compare that against one another, and it can also be a data quality check. I certainly agree with that. That is certainly a prerogative. I think that the general rule of thumb, though, is to try to minimize the data capture as much as possible. Just thinking about the reporting burden being so critical, such a critical consideration at the facility level.
Scott, if I can come in there, I think ANC first visit is a very good example. ANC first visit is required by RMNCH, that's fine. ANC first visit is required by PMTCT, that's fine. And ANC first visit is required by the malaria program. So what happens is, if you ask for that same variable on 3 different forms, you will, more often than not, get 3 different answers. And so then the question becomes, well, where is the source of truth? Which form, which value, which figure do you accept as the correct value? And then you discover, no, but the malaria program collects from the 26th to the 25th. The HIV program is from is a calendar month, and the RMNCH has some other variation, week 1 to week 4. And so it becomes very difficult to try and make sense of all of this. So where possible, try and have just one variable for one data element, ANC first visit, because otherwise, and we saw in some of Nick's thing about form design, what happens when you have two programs collecting the same data? Who speaks the truth? You don't know. And so be very careful of trying to collect this data and say, well, we want to validate it. All you do is create headaches for yourself and the facility staff.
Right. I do want to move on to this next video. This one is more for your system administrators out there and trying to appreciate how to maintain